hernia situations I've never met before. And after doing the preparation for this talk, sorry my friend, I decided to add a subtitle. Or let me say, I don't want to see that again. Okay, let's make the best of it. You know my disclosures, I always want to sit on the right side of the limb, and once more, thank you very, very much, both of you. Maybe you expect, after this, let me say, firework of difficult cases, another firework of more difficult cases, disasters, complication. Well, no, I decided not to do that. I want to show you a case that could happen again every single day in your institution. And this is what I'm really concerned about it. Let me tell you a story about a nice guy, Austrian guy, named Peter. Peter was 60 years old when the story began to get a little bit difficult. At that time, a BMI of 42, hypertension, appendectomy as a child, open cholecystectomy in an external hospital. They made a conversion from laparoscopic approach to an open approach due to obesity. Well, the patient was planned in November 2015 for bariatric surgery. The colleague who did the operation performed laparoscopic approach and had to convert to an open Roux-en-Y bypass due to short mesenterium of small bowel and performed a median laparotomy. This is citation from the OR report. Things can happen, yes, okay. Almost a year later, one could wonder maybe someone could find the aortic aneurysm before doing gastric bypass surgery, but nevertheless, July 2016, aortic aneurysm and incisional hernia repair PM2 to 3W2. Well, someone can say, oh, no, nothing to worry about, this is our job. Yes, this is our job. I did the case together with our vascular surgeons. They made a tube graft interposition, and I did the reef stopper repair. Completely uneventful course. Well, you might say, bad luck, shit happens, nothing to worry about. Yes, you're right. But the story of Peter goes on, of course. 1 year later, Peter went to the emergency clinic due to quite severe epigastric pain, and diagnostic follow-up, diagnostic workup showed a blind loop syndrome of the side enterostomy of the gastric bypass. And the same surgeon who did the gastric bypass performed laparoscopic adhesivolysis, resection of blind loop, and another citation from the OR report. Trocars are placed open without any problem, just a few adhesions, uneventful course. Well, more than a year later, Peter came back for a bariatric checkup. BMI was 27, yoo-hoo, perfect. Abdominal wall is fine at that time. Just a little dumping when eating sweets or ice cream. Peter said, well, nobody has told me not to do that. Another hint that obesity is a disease of the brain, not a disease of the stomach. 1 year later, Peter came to our hernia consultation due to a swelling of the left lateral abdomen, increasing discomfort, even pain at activity. You may think that, well, perform a CT scan, this is what we found. We found a partial disruption of the left semilunar line with incisional hernia at the trocar site PL2W2. Remember, please, we have a situation after an open reef stopper repair. We decided to perform a pre-op Botox. I apologize, these CT scans are 4 weeks after, right before the operation, 4 weeks after the Botox infiltration. The reason for doing Botox was that I wanted to reduce traction at the closure site to the lateral of the abdominal wall. And we decided at that time, maybe nowadays I would prefer another technique, to do an open revision with TAR left and a retromuscular PVDF mesh implantation. This worked fine, defect was closed, uneventful course. Peter is a nasty guy. He doesn't have enough yet. He came back to me, to the hernia clinic, because of back pain. His family doctor told him, well, it could be a recurrent hernia. Workup showed discus herniation L2, L3, L4, L4, L5, L5, S1, and we said, well, Peter, look for a good physio. 1.5 years later, another hernia clinic consultation due to on the right side. The operation was made on the left side, remember? Because Peter, he's a very cooperative guy, returned the questionnaire of the hernia made registry and was invited for re-evaluation because he reported, you can suggest, back pain. We performed another CT scan, a dynamic procedure without any recurrence, not in the midline, not in the left lateral quadrant. We found, no wonder about that, the discus herniation, and sent the patient to the orthopedic clinic to get some consultation about all the findings, and they sent him back. Normal finding, well, discus herniation is normal nowadays. Pain must due to the hernia operation. Oh, ouch. Well, we sent Peter back with a recommendation of conservative treatment. And Peter did that and was quite satisfied with the situation after some time, but came back to the vascular surgeons with another aneurysm of the right femoral communis artery. They did a reconstruction. Peter suffered from a post-operative lymphocele which needed an open revision with drainage. And then, shit happens again, another aortic aneurysm at the proximal tube graft, which was planned for endovascular stenting. Peter had this procedure 3 days ago and is still fine. I saw right before traveling here to Bucharest his abdominal wall and is still stable. So what did I learn from this case? I think it's our responsibility to teach our colleagues, if not possible, well, discuss about that, but we have to teach our residents, don't dare to touch that semilunar line, even if you insert your trocars. Thank you.